Let me thank Dr. Manish and Dr. Rajat, my close friends, for the kind invitation. The topic that I'll be discussing in the next 20 minutes is what were the new updates in this year, ASCO 2022, with relation to breast cancer. So in a nutshell, I'll be covering the following 6 things. Some are practice changing and some slightly clear some of the questions that we have in our clinical practice. The best and the practice changing study, and probably what got a standing ovation, was a Destiny 4 study, which was presented by one of our Indian, Dr. Shanu Modi, trastuzumab deruxtecan in HER2/neu subset. The final overall survival of Paloma 2 study is highly eagerly awaited study. Phase 3 data on TROPiCS-2. So antibody drug conjugate secukinumab govitecan in hormone receptor positive. Remember your ASCEND study, which was in hormone receptor negative. And there were answers to few of the important questions that probably we keep on doing in our clinical practice, but for the first time we had our proof of concept. Can CDK4/6 inhibitor can be given beyond progression? Can radiotherapy be avoided in early breast cancer undergoing breast conservation surgery? So early T1 stage OR luminal B, can we avoid RT? And one of the most important thing again was, we know that bisphosphonates are recommended in adjuvant setting along with AI. The question there, this was answered, was can denosumab be given in postmenopausal early breast cancer taking AI instead of zoledronic acid? And now we have a OS data also, which was a positive study. So I'll be covering it into 2 ways: hormone receptor positive and basic HER2/neu related, which is low or non-amplified. Let me start with hormone receptor positive thing. So the first data that came, our first phase 3 where we were, that was an eagerly awaited study, was the final OS data of Paloma 2. Everyone remembers the PFS, which was twice, and the first CDK4/6 inhibitor, which showed advantage in metastatic setting. And this was the final overall outcome of Paloma 2, which is a first-line palbociclib in de novo HER2/neu hormone receptor positive, HER2/neu negative metastatic breast cancer. So palbociclib plus letrozole versus letrozole in postmenopausal women with ER positive, HER2/neu negative, no prior treatment in advanced disease. The primary endpoint, which had been published earlier, was positive with the PFS, and in this we had a final overall survival analysis. Now, without going into details, the final OS was 53.9 months as against 51.2. Not statistically significant. So unfortunately, the secondary endpoint of this trial, that was negative, palbociclib did not prolong overall survival. Now, they did some subset analysis where there was a subset of patients. You remember, they had taken around 20% of the patient where the disease-free interval was less than 12 months, as against other studies which did not take it. So if you exclude that subset, for a subset of patients where the disease-free interval was more than 12 months and they were taken, the OS was 64 months versus 44.6 months, with a statistically significant reduction in the risk of death by 27%. But please remember, that was not a subset planned analysis, and that was an exploratory analysis. So all in all, Paloma 2, a first-line data, was a negative study. Probably multiple reasons could be there, but one of the important reasons was the heterogeneous population taken in the study. Probably some differences between the 3, but for now, this was a negative study in terms of OS, but that was a secondary endpoint, not a primary endpoint. Now coming to my second study, can we give CDK4/6 inhibitor beyond progression? So this was a randomized, but a phase 2 study of fulvestrant or exemestane with or without ribociclib after progression on any anti-estrogen therapy plus a cyclin CDK4/6 inhibitor in unresectable or metastatic hormone receptor positive, HER2/neu negative cancer. That is a maintained study. So if you see in detail, these were ER/PR positive, progression on endocrine and any CDK4/6. More importantly, either no chemotherapy or at the most one chemotherapy had been taken in a metastatic setting, given ribo plus endocrine. Please remember, it was both switch most of the patients. So a different CDK4/6 inhibitor and a different endocrine therapy. The primary endpoint was a progression-free survival. Now, these were patients where most of the patient had taken preceding line as a CDK4/6. So we continued CDK4/6 beyond progression on a CDK4/6 inhibitor. However, most of the patient, that is 87%, had taken palbociclib. More importantly, they had responded in the first line on a CDK4/6 inhibitor. So approximately 16 months, and the drug that was chosen was either a fulvestrant or a exemestane. Now, when you look into the primary endpoint, there was twice in terms of quantum absolute 2.15 months absolute improvement in terms of progression-free survival, and in terms 43% reduction in the risk of progression, which was statistically significant. So yes, it satisfied, or the trial was a positive trial with a statistical significant improvement in progression-free survival. More importantly, 2.5, we need to remember that at 1 year, more than 3 times the patient were progression-free on ribociclib as against placebo. So rather than a quantum of 2.5, the more important is long-term benefit. There were 3 times more patients who were progression-free at 1 year. Now, a subset of patients had already on ribo and they continued ribo beyond progression. And if you look into both these subsets, there was an improvement in statistical significant improvement in progression-free survival. After all, in all other subsets also, whether bone, visceral, age, white or non-white, or 2 or more on endocrine therapy. So that was a positive study. So what is the strength? A first randomized trial addressing the question, a well-designed study. But again, we need to remember that this is a small study and not a practice changing. Probably we will need data from the next 4 studies that I have written here: Palmera, PACE, AMBER, post-MONARCH. Probably with these studies, we'll be more clearer in our view that whether we should continue CDK4/6 same or different beyond progression. So the second take-home message is continued inhibition of CDK4/6 beyond progression is feasible. However, we need further studies till it becomes a standard of care. The third study, again an important study in those with a hormone receptor positive, regard TROPiCS-2, a randomized phase 3 study of sacituzumab govitecan. Please remember, a drug antibody conjugate against TROP2 antigen. So we had ASCEND study in triple negative, but this was in hormone receptor positive. And this study for a heavily pretreated patient in hormone receptor positive, HER2 negative metastatic disease, who had already received endocrine, CDK4/6 and prior chemotherapy. Try to look into the subset of patients. At least 1 endocrine and a CDK4/6, 2 to 4 chemotherapy. So heavily pretreated patient, sacituzumab govitecan versus a treatment of physician choice, which could be capecitabine, vinorelbine, gem or a eribulin. The primary endpoint was a progression-free survival with all the other secondary endpoints. These were heavily pretreated patients. So 95% visceral disease, median chemotherapy cycle 3, and metastatic disease for more than 4 years. So I have very heavily treated patients. Again, this was a positive study. In terms of absolute benefit, 1.5 months, but around a 34% reduction in the risk of progression. Again, I like you to look into the 12 months PFS. So 3 times more patients were progression-free at 1 year with sacituzumab govitecan. So again, exciting time, one more drug option here in a hormone receptor positive metastatic breast cancer. Now, when we talk about the response rates, 21% response rate, 34% clinical benefit rate, but more importantly, around 7.4 months duration of response, which all was statistically better as compared to treatment of physician choice. What about side effects? So only 6% treatment discontinuation, 33% dose reduction, and more importantly, only 2%. So a drug in a heavily pretreated again continues to show a good response with a manageable toxicity. Of course, the toxicity is like an irinotecan, so the active principle of SN31, diarrhea, febrile neutropenia, and some neutropenic colitis. All in all, a safe drug in this line of therapy. So a well-designed phase 3 study, a positive study with 34% reduction in the risk of progression, no new safety signal. But again, I like you to be a bit careful that the quantum of benefit was only 1.5 months. We need to look into OS now, which is still not mature. And although there was some benefit in quality of life, but we need a longer data till we incorporate this drug into the clinical practice. So the third take-home message is sacituzumab govitecan, one of the new options in the management of hormone receptor positive subset. The most important study for today, the practice-changing and the study which got a standing ovation, trastuzumab deruxtecan in HER2 low breast cancer, the data of Destiny Breast 4 study, which compared this with treatment of physician choice. Now, when you look into this HER2 no, it is defined as IHC 1 plus, IHC 2 plus, or in situ hybridization negative. And if you remember, or if you consider overall, around 45 to 55% of the patients are in this subset of patients who are HER2 no. So you can remember how many new patients or how many new number of patients of breast cancer will be benefited from the study. So again, look into the population. These were HER2 low, unresectable, 1 to 2 lines of chemotherapy in the metastatic setting or recurrence less than 6 months after adjuvant. So a poor subset patient, one or more than one endocrine therapy, ER, hormone receptor positive disease. So again, a pre-treated patient with trastuzumab deruxtecan 5.4 mg per kg 3 weekly versus chemotherapy of physician choice. The primary endpoint was PFS, and the secondary endpoint included overall survival and safety. Now look into the number of treatment. At least 3 chemotherapy systemic lines of treatment had already been taken within the range of 1 to 9. Around 67% of the patient, it was 4th or more line of treatment. Around 61% of patients had taken at least 1 chemotherapy. It was a second line in terms of chemotherapy. And when you look into endocrine, majority had taken 3 or more than 3 lines of endocrine therapy. Around 70% had already received a CDK4/6. So all in all, a heavily treated population. Now this was unprecedented. A 4th or a 5th line treatment with a PFS of 10.1 months versus 5.4 with the absolute gain of 4.7. A statistically significant improvement with a 49% reduction in the risk of progression in the hormone receptor positive. All in all population also, this hazard ratio was even more impressive with 50% reduction in the risk of progression. So a highly impressive data, practice-changing data. Now, icing on the cake was an improvement in overall survival also. So close to 3 years, 2 years, 23.9 months, a 36% reduction in the risk of death, and an absolute gain of 6.4 in the hormone receptor positive. And these results continue to be same or better in all the patients. Now, when you look into the hormone receptor negative, which was in a minority, this quantum of benefit, so absolute gain of 5.6 months with around 54% reduction in progression. More importantly, again, the OS there was a 52% reduction in the risk in the hormone receptor negative. So both ER positive and ER negative, the benefit was continued, probably more better in the hormone receptor negative subset. A highly impressive response rates of 52.6, or I can say more than 50%, 70% clinical benefit rate, and a very high duration of response of more than 10 months. So what about toxicity? So 53% grade 3 toxicity with, again, less than 1/5 disease dose discontinuation and around 23% dose reduction and a very few deaths. ILDs, what we were about, was less than 10%, and nausea and fatigue was also manageable. When you talk about adverse events of special interest, C grade 3, 4, 5, TDXD less than 2%. When you talk about cardiac, grade 4, 5, 0. When you talk about cardiac failure, grade 4, 5, 0. So all in all, the drug which was the side effect was as we discussed previously, and it was manageable. So if I have to summarize this, a practice-changing studies, around 50% improvement in the risk, in reduction in the risk of progression, and more importantly, 36% reduction in the risk of death when we give this drug. The first anti-HER2 antibody to demonstrate this in HER2 low, similar benefit across all, safety was manageable. So the fourth take-home message is TDXD now a new standard of care in HER2 low subset of patients in this one. We remember these are 50 to 60% of all breast cancer patient. What about early breast cancer? So in next 3 minutes, I'll finish off these things. An important question, Lumina study. Can we avoid radiotherapy following breast conservation surgery in early luminal A? So less than 2 centimeter T1 luminal A breast cancer, and probably one of the good studies that was published. So basically they try to determine in these low risk subsets, so combining clinical pathological factors and luminal A to see that whether you can avoid radiotherapy in this subset. So please try to look into it. T1 more than 55 ER positive with a Ki 67 of less than 13.25%. And the main thing was that the local recurrence rate should be less than 5% at the end of 5 years. So what they observed was in this subset of patients, when you omitted your radiotherapy, the local recurrence rate was only 2.3%, less than 5% that they had thought of. Now, when you look into the other recurrence rate, 1.9% contralateral breast cancer, any recurrence 2.7%, a DFS of 90%, but more importantly, overall survival of 97.2. So they thought of 5% as a local recurrence, it was only 2.3. So probably what they concluded is, yes, this approach is feasible because anyhow, the local recurrence rate is only 2.3%, and it satisfied the pre-specified boundary. And it supports that this, we can think of omitting the RT in this low risk subset. So the fifth take-home message is, considering the low risk of relapse in this subgroup of patients, we can think of omitting radiotherapy. The last study. We have remembered that we normally nowadays, or we give zoledronic acid every 6 monthly in post-menopausal carcinoma breast patients who are on aromatase inhibitor. What about denosumab 60 mg every 6 monthly? We already had a fracture reduction data in 2015, but this was the final survival analysis in this 3,425 Austrian breast cancer study group 18 study. One of the most, again, talked about studies. So early breast cancer, ER/PR positive, randomized to denosumab 60 mg subcutaneously 6 monthly versus placebo. Now you should not have taken bisphosphonate. Now this was something that was published in ASCO 2015. There was a statistically significant improvement in terms of time to first clinical fracture, 50% reduction in the risk of first fracture. But this was what that was published in this ASCO. A statistical significant improvement in disease-free survival. 17% reduction, but more importantly, 5.4% absolute gain in disease-free survival at the end of 5. When you look into bone metastasis-free survival, again, a statistical significant improvement of 19% with an absolute gain of around 5%. And more importantly, again, even in overall survival, the gain was there of around 5%. With a 20% reduction in the risk of progression. So that is something amazing. Apart from reducing your fracture risk, it also improved DFS as well as OS. So what did this study conclude? That denosumab 60 mg every 6 monthly during AI therapy is safe and markedly reduced treatment-induced clinical fracture, but more importantly, disease-free survival, bone metastasis-free survival, and or overall survival was improved by giving this drug. So now we have one more drug apart from bisphosphonate that we can give it in every 6 monthly. There is some advantage in terms of avoidance of hypersensitivity. You can give it in a renal failure patients also. So the sixth take-home message was denosumab along with bisphosphonate now the standard of care in adjuvant setting in patient on AI. You can give your bisphosphonate or you can give denosumab, for then we have a OS advantage also. The last thing, should I give a GnRH analog in those patients who are premenopausal and after chemotherapy still menstrual function is retained or the patient is premenopausal? So this was the trial which combined tamoxifen with gosiranen. Please remember, gosiranen is given only for 2 years and the primary endpoint was a disease-free survival. So the primary endpoint at 8 years was statistically significant. I practice this. If the patient is still menstruating, I give 2 to 3 years of GnRH analog. And this trial also suggested that there was an absolute gain of more than 5% with a 33% reduction in the risk of disease progression at 8 years. So yes, we have a data now to support it. OS, since it was across, the OS was not statistically significant. So the seventh and the last take-home message is adding ovarian suppression, an important consideration in women retaining ovarian function post-chemo in hormone receptor positive early breast cancer. So even after chemo, if you have the menstrual, you can add on to improve your DFS advantage. So if I have to summarize my breast cancer update in this, if you can remember this, you might have covered everything. Paloma's 2 study failed in a secondary endpoint. Continuous inhibition of CDK4/6 beyond progression is visible. Sacituzumab govitecan, again a new treatment option in hormone receptor positive metastatic breast cancer. Trastuzumab deruxtecan, new standard of care in HER2 low metastatic carcinoma breast. Radiotherapy can be omitted in subset of early breast cancer patient undergoing breast conservation surgery. Denosumab, a treatment option in adjuvant setting in postmenopausal patient with a survival advantage. And last but not the least, adding GnRH analog along with hormonal therapy in patient retaining ovarian function post-chemo improve your disease-free survival. I thank you all, and I always say this is one of my previous quotes. The secret of change is to focus all of your energy not on fighting the old, but on building the new. And I again thank the organizers for the kind invitation. Thank you all.
Thank you. Thank
Good
you,
evening,
sir.
Good evening.
Nice.
First, sincere apologies. I
presentation.
had some party, so I could not attend there. So I called it early morning. I just came out. Hope I answered or I completely covered. This was the 6th most important abstract. And I think there was a lot of good things that came up in this ASCO 2022.
Yes, sir. Yes, I agree. Sir, what is your take on the use of denosumab? Are you now going to use denosumab in almost all your patients in the adjuvant setting?
Yeah. A advantage in terms of you don't have to give a IV. It is subcutaneous. We all know the other advantages like no hypersensitivity, renal things. So I think so more or less. Actually, we have been using it in those who are not fit for zoledronic acid till now. If you ask me, we have quite a few patients, but now you can safely use in other patients also, because now we have a phase 3 data which more or less says the same thing, that either you use a zoledronic acid or a denosumab. Being a 6 monthly, I don't think cost will always be a constraint. And I think so that is, again, if you say it is practice changing, or now I can say a practice reinforcing study, because some of us are using it in those who are not fit for zoledronic. Maybe now we can use it for all our patients with the data available, sir.
Okay. And of course, like you said, the most practice-changing study is the Destiny Breast 04 on HER2 low patients. So, do you think that once trastuzumab deruxtecan is available, it is going to be the most sought-after drug for all our patients in the different settings?
Perfect. If you just remove your triple negative, apart from that, for all the patients, you will be using this drug. Of course, the quantum of benefit, if you are HER2 amplified, it will be pretty high. If you have seen in the Destiny study, previous Destiny, which compared it with trastuzumab. But the good thing about it is, if you are not HER2, if you are not triple negative, you can use this drug in all of your patients. So yes, fully agreed that this will be the most sought after drug and probably a game-changing drug for this entire 70 to 80% of the patient. Now, and again, we need to remember that 10 months was after it was a 4th line. So maybe if you use it earlier in this HER2 in the first or second line maybe after a CDK4/6, this 10 months might still be 16 to 20 months. Maybe I am assuming, but yes, probably earlier lines, as we have seen in HER2 amplified, the quantum of benefit is more. This was a 4th line average. And with a 10 months 4th line, something that was never thought of also. So probably yes, again a game changer and more sort of drug. Agree with what you said.
Right, sir, right. And of course, now we have a little more validation about the use of CDK4/6 inhibitors post CDK4/6, which some of us were doing because the patients used to have a good performance status and they never used to like the fact that they were going to be started on chemotherapy. So that also is a little more validation now.
Again, if you look into, I'll tell you, if you have a time, go through the flat iron data of use of CDK4/6 inhibitor in US population. In fact, they suggested that post CDK4/6 progression, the best PFS in those who are not PIK3 mutant was continuation of a CDK4/6 inhibitor. So probably in real life, many of us have been using it with the scarcity of the option available. And for the first time, we have a proof of concept. In fact, I'll be more excited when we get the data. For me, Abema is one of those drugs which works very well in a refractory setting. And there are 2 studies going on for abemaciclib. And we know that second agent Abema, as per as Monarch 1, also had a fantastic response. So I think more or less, again, we were using it without any proof of concept. Now, for the first time, we have a data which says that although the placebo arm was only 2.75, but yes, 5 months, but I would again like you to concentrate on a 12-month PFS. So if you respond and if you keep on responding, 20% of the patient was still progression-free for at least 1 year more. So that is something that is, you have a long-term response. If you are responding, it is good that you may respond for more than 1 year. So that was more a take-home message rather than this 5.5 months. And I agree, we have been using it, and probably this gives us more proof that what we were doing or what we can do is correct.
Right, sir. And the final question, I'll not hold you for long. I know that you're busy. Is that the last thing about the use of your preference about the first line use of CDK4/6? So Paloma 2, the secondary endpoint was negative, but then do you think that it was just the subset of population that they had taken because there was more pre-treated population than the Mona Lisa 3 study?
No, if you ask me, somehow I feel it could be one of the reasons of that patient with a less than disease-free interval 12 months. But I will like you to leave about your first line. In the second line, the data of Paloma 3 was negative. In the adjuvant setting, Palas study and Penelope study, that was also negative. So I feel there is something more than the drug. I strongly feel that all the 3 drugs are different. Yes, in a first line, I think so. Now with the data available, maybe there is a slight inclination of using a ribociclib rather than a palbociclib, and I'll say maybe a abemaciclib, because unfortunately, if you look into the Abema people will beat me. If you look into the interim OS analysis of Monarch 3, I'm repeating myself. Monarch 3 is the first line data in an interim is not statistically significant. It is 67 months Monarch 3. That is first line Abema, 67 biggest, but that was not statistically significant. So if you say data-wise, Palbo failed in the first line. Abema till now has not shown OS advantage as far as interim analysis. So with the data available, Ribo should be used in the first line with the data. Although I strongly feel Abema may be positive and in a longer run. For a second line, I feel the best data is for abemaciclib, more in the endocrine resistant. But yes, some out in the endocrine after 2 years thing also. So I feel now is the high time that you should think that these 3 drugs are not the same. And you have what we say, horses for courses. You should be individualistic in seeing the situation and then making a choice about things, apart from what you see based on your side effect profile also.
Right, sir. So, thank you so much for a very detailed discussion on the new updates which have come, and I believe that most of these updates are going to be not only practice changing, but they are going to be very much into our practice in the coming year or so. So I thank you once again for sparing time for a very nice and
my pleasure. I
as always.
absolutely, it is privileged to be part of your we always learn some new things from you. Thanks for a kind invitation.
Thank you, sir. Thank you so much. The feeling is likewise.